to On Becoming a Healer. I'm Saul Weiner. My co-host, Stefan Kertez, is away today. As you know, in each episode in this podcast, we talk about keys to becoming an effective healer and helping others become effective healers. Through stories, we focus on themes of engagement with others, boundary clarity, a sense of shared humanity, a lack of judgmentalism, and other attributes necessary to being an effective healer. Today, we have a guest, Dr. John Scala. John is one of 3 physicians featured in On Becoming a Healer in a chapter titled Healers Are Realists. Recently, we interviewed Lamenta Conway, who is also one of the 3 individuals. As I mentioned, I met Lamenta early on in my years as an attending physician. I had become a program director at a new institution after completing my residency, and it was really around the same time that I met John. John was even closer in age to me. He was already, I think, in his 3rd year of a 4-year medicine pediatrics residency when I came on board as a young attending, and this was in the 1990s. And one of the many things that stood out for me as I got to know John was, first of all, how much he enjoyed being a resident. And that was not that common in those days. It probably still isn't. But we didn't even have a work duty limit at that time. Starting at around 2000 or so, work hours changed to the 80-hour work week for residents, which is still an awfully long week. But in those days, there still wasn't really any cap. And one of the things I remember is that after a busy afternoon clinic, John would often just look around to see who had to go back to their inpatient service after a long, exhausting night to finish up their work. And he would just say, hey, let me come with you and I'm going to help you get your work done so you can get out. And that is very unusual. In fact, I've never seen any other resident do that before. Just, at a time when we were working 100 hours a week or more, time off was precious. And so for a resident to kind of step out and say to other residents who were exhausted after a long night, hey, how can I help you? Let's go get your work done, is just very unusual. And so when I was thinking about writing On Becoming a Healer, I developed a chapter, I think it was chapter 8, which is called Healers Are Realists. And I was trying to think about residents or former residents who I wanted to look up. But I was interested in learning a little bit more about what had happened to a few of the individuals who stood out for me during residency because they enjoyed their work, because they were so helpful. None of them were starry-eyed idealists. That actually was not the prototype that I saw. I was struck by how pragmatic these individuals were. They just did their work, but they also didn't complain a lot, and they seemed to take a lot of pleasure in what they did. So when I looked John up, I was maybe not that surprised to discover that he had just dozens of rave reviews online from many, many patients. And a lot of them were really heartfelt and detailed, talking about how important he had been to them in one way or another and how much he stood out as a primary care physician. John has been in a number of practice settings. After residency, he married another resident, a pediatric resident, actually, who was from Japan. And so she was on a J-1 visa. So they ended up going initially to a practice in Utah. And then he ended up at a practice in Illinois. And then he went back to Colorado. And what was striking is that he actually built these practices pretty much from the ground up, or literally from the ground up. And in some cases, he even did the electrical wiring himself. So without further ado, I want to introduce you to John. I'm going to start by asking him a little bit about his background. And then we're going to talk about what's going on these days during the COVID pandemic. This conversation has been divided into a 2-episode podcast, with the first focusing on his experience in practice, and then the second specifically on the COVID pandemic. John is a primary care physician with a solo practice in a small to mid-sized city in the Midwest. And I think the stories he has to tell and the challenges he's dealing with will probably resonate with many of our listeners. So, John, welcome to On Becoming a Healer.
Well, thank you, Saul. That was a nice introduction. I appreciate being here today.
Let's start by talking about how in the world did you decide to become a doctor, and where were you at that time in your life?
So that's a great question. So I was a very good math student, and I ended up in engineering school at Johns Hopkins. I was also accepted to the University of Illinois, but my father kept pushing me to go to the East Coast, which at the time in the 80s was very far away. So I ended up going to school there, and despite doing well in high school, it was extraordinarily challenging for me, and I ended up only being a B student. So I figured that since I wasn't that good at biomedical engineering, I should try a different career pathway. First, I went to the military to see if I could get some financing or a scholarship. And after all the testing and different situations that they put you through in the physical, they determined that my hearing was outstanding. We're talking 1 in 10,000 people. So at that point, they decided that the best place for me would be in the sonar room of a submarine. And I told them I'm from the Midwest and I couldn't be underwater for 6 months. So after that, I got some loans and I applied to medical school and entered medical school at the University of Illinois. I'd financed it all myself, of course. Of course, it was cheaper back then also. So that was kind of my story. I was really hard set on being an engineer all my life. And when I decided it wasn't as, one of the top bananas, I decided on a different career. Medical school was harder because it was all memorization and not much analyzing, which is what I was used to in my engineering studies and research. But getting past the memorization and getting the solid block of knowledge cemented in the brain, that was the time for the analytical process, and I really enjoyed it. So that's kind of the story of how I got there.
You know, it's interesting. I've noticed that you've always enjoyed keeping up to date and knowing what's going on in your field. And you're now a primary care physician in a rural area, and that's not a rural area. I would say in a somewhat isolated environment. You're not in an academic medical center, for example, the way I am, and yet you're somebody who is always up to date and kind of reading the latest stuff and interested in the basic science. And I'm just curious about what drives that. Tell me a little bit about that.
Well, that's twofold, actually. The first is just interest. I mean, medicine is interesting. There's a lot of changes. So there's the academic side of it. And I have, for the last 6 years, had a resident with me on a monthly basis in my private office. So I think it's important for me to know at least as much as they do with all the new evidence-based medicine. So throughout the years, I've read at least, I guess if you average it out, it would probably be at least an hour a day, frequently 2 hours a day. And then, being med peds, I've taken a lot of board exams. So I dedicate a complete year of studying prior to each board exam, be it medicine or pediatrics, in which I generally earn between 400 and 500 credit hours with all the studying. I just block the schedule. My family's on board with that. I've taken the medicine board 3 times now. The last one was last October, and the pediatric board 3 times. So that's 3 years of intensive study to get up to date and to make sure I do well in the exam.
So going back to the earlier phase of your career, we were talking about your going through medical school, having to do a lot of memorizing, and then entering a medicine pediatrics residency. What was it that prompted you to choose primary care medicine pediatrics residency? And I ask that because often I think of the kind of individual who has the course you were on, which is kind of majoring in biomedical engineering and more likely to go in the direction of a procedural or specialty field. So what was it that led you into a med peds residency and then the decision from there to stay in primary care?
Well, that was 2 issues. So the first issue is honestly, I'm not very coordinated and my vision isn't very good. So, so from a practical standpoint, I wasn't good at piano. I wasn't good at, I'm good at fixing things, but it just takes a long time and I'm not coordinated at it. And then my vision wasn't always, very good. So just from a practical standpoint, I didn't think that technically a procedure-oriented field would be the best for me. Now, the other side of the coin is that when I was in engineering school, we learned systems engineering. And as most know, the most complex machine ever developed is the space shuttle. And that's, multiple systems interacting together. And so I got to thinking about it. And I thought, well, by far and away, the most complex system is the human body. So to integrate all the systems in the human body would be probably the pinnacle of using my engineering skills, plus just something I was interested. You can sit for hours and think about a case or figure something out. You can read and get details, build up the knowledge, and try and figure it out. So it was the intellectual side I thought would be something that could stimulate me for a long period of time, even when perhaps my vision failed. And I can still help people long term by using the knowledge base plus the analytical skills I've learned throughout the years.
Now, many physicians in primary care complain of being burned out. They feel that, once you've seen 1 cold or 100 colds or 1,000 colds, you've seen them all. And the same goes for much else that presents in primary care, the aches and pains, the chronic medical conditions that people come in with over and over again. And you have not burned out. In fact, it's pretty clear from the reviews that I see online about you that you're anything but. Tell me a little bit about how somebody who trained initially to think as an engineer finds so much stimulation in primary care.
I think the majority of it is just curiosity about people. Every time I step in the room with a patient, I'm genuinely curious about this person. Like, what's their life like when they're not sitting in front of me? And this way, they can trust me from an early thing because I'm asking them questions. Everyone wants to talk about themselves. And so to treat them properly, I have to know, what their life is like at home, what kind of work they do, what their exercise is, and all these little details that aren't, necessarily on their medical problem list, but that makes the full picture of the person. So it's just an intensely curious attitude just about people in general. And not only does it help me treat the patient better, it helps them to trust me more, go along with my recommendations, and just overall better experience for me. I enjoy when people come in because I'm curious what happened next in their life.
So when you get up in the morning and you're headed off to work, what's going through your mind as you head into your busy practice?
Yeah, so the first thing I do when I wake up in the morning is I give a little prayer thank you that I was born with the intelligence to help people. And, I do my stretches and then I go on my way. I spend about 2 hours in the morning alone in the office. I get here super early and kind of organize my day and look through who I'm going to see today and try and remember some of the details. It's actually kind of fun because, I might see that, someone was anticipating their daughter getting married. And so I can remember that little pearl. And even if they come in for a cold or they come in for, some follow-up of some issue, I can mention that. And, of course, the person's excited to talk about that. And then we go on to whatever's bothering them. So we integrate a little bit of who they are with whatever's going on from a medical side. So it makes, I think, for a less stressful and more enjoyable experience, both for them and for me, because, I'm curious about what happened with this or what happened with that. So I think it has to be a mix. It can't just be the hypertension, diabetes diagnosis every time. You have to look at the person as they are. And I don't know why it works, but I just think it's interesting and it makes it fun to go to work every day.
And how do you cope with that feeling of time pressure that so many of us feel when there's a waiting room, other people waiting, patient wants to talk about more, and you're concerned that you could be getting behind? Tell me a little bit about that experience, which is so common to primary care physicians, and how you respond to it.
Right. So I don't overbook, and I've developed a scheduling system over the last 20 years where that's a rare occurrence. Maybe once a week or once every 2 weeks I'll get behind, but usually it's in a situation where there's enough space, at lunch where I can catch up and then be fresh for the next session. So I think in the last 2 weeks that's only happened once. And that was a case where a family brought in one baby, and the older child actually had a well visit scheduled, but it was listed on the schedule as just a flu shot. And so I happen to have a resident, so I had the resident see the next patient, and then I went in with the next patient. So that helped out. But yeah, I get anxious when I'm off schedule, probably more so than my patients. But they're all very understanding because it happens so rarely. So I'll go, if I'm running late, I'll excuse myself from the one patient. I'll go and talk directly to the other patient and say, hey, look, I'm running like 15 minutes late. I'm really sorry. And, as long as you explain it to them, it happens with rare enough frequency that no one seems to mind because, 90% or greater of the time, people are seen within like 2 minutes of their assigned time, as long as they come on time, and they know that too.
When you're setting up your schedule, the way you mentioned, to avoid having this happen often, how do you structure it?
So what we do then is, so I've, obviously scheduled physicals and well child visits and follow-ups, okay? And then certain patients, we have a little flag in there. They're always 30 minutes because they always say, ask extra things. So that helps relieve the pressure on the schedule. But there's every block, either morning or afternoon session, there's 4 open slots. So people can call for same-day visits for those. But if it looks like, it's running over, then, we can shuffle those same-day slots so there's a little extra time.
Do you see fewer patients than primary care physicians in other practice settings? In other words, do you reduce your burden of patient volume so that you have less of a time crunch?
I'm not quite sure what other folks are doing. It's a little different this year during the pandemic, but my half days, I'll see usually 12 patients, and on my full days, it's 18 to 20. So it's probably about the same. Anything more than that, you get kind of tired and burnt out. So I just do enough to pay the, expenses and have a decent average. Actually, it's a low salary comparably, but I don't mind that.
Yeah, the reason I ask is I think this willingness to accept less than a high salary is a decision physicians have to make. For some physicians, having a high salary is a priority, and that requires seeing more patients. And for other physicians, the decision is tilted in a different direction, as it is in yours. How do you think about making this trade off between deciding how you're going to structure your practice and how much money you're going to make?
Yeah, so we decided early on in our marriage, and it's just been my style too, to not live for the mortgage, to live, an upper middle class or middle class lifestyle. And it just reduces the stress across the board, so you have the freedom to kind of live your life the way you want to live it. And that was a great decision. Just move into a regular neighborhood and, buy used cars and keep your cars for 10 years. And because then you're not always chasing the debt. So you can choose if you want to, in the middle part of your life when you're starting to get tired, you can not necessarily have the highest salary and still live a comfortable life and really enjoy it. So I'm kind of glad I made that decision early on. I see a lot of these neurosurgeons and orthopedics and so on, and they'll buy the $4 million house and they're working and they're never home for their family. My girls are teenagers and I've been home for dinner every night at 5:30 to eat with them. Now I might go back and have some work to do or make some phone calls afterwards, but every night we've eaten together, and that was just one of the things that was important for me.
Now, tell me a little bit about how you deal with the paperwork, particularly the charting. What happens during a visit, and when do you do your charting? And tell me a little bit about that.
Right. So I have a clipboard with a blank sheet of paper on it, and so I'll sit and talk to the patient, directly looking at them and jotting down notes. The computer, the laptop is in the office, but it's only to reference like the vital signs or, the recent labs or the x-rays or maybe something from a previous note. In some cases, if I think I need full attention with the patient, I'll print out the previous visit and put that on the clipboard just so that I can watch the patient the entire time. So what I saw was I tend to, if I use just the computer, then I miss all the subtle aspects of the patient. Like, are they pill rolling their thumbs? Or are they shaking their legs? Or, how's their eye contact? So I don't want to miss any of those details. And so I'll just talk to them like I would with a normal paper chart. I will do the dictation afterwards. So I use a Dragon Medical System with my EMR, and that works pretty well. So if I have time, I'll do it between patients. Otherwise, I'll do it over lunch or at the end of the day. Okay. And some days are really difficult days where I'll have to do some in the evening, but that's probably only once every 5 to 10 working days. Most of the time I can knock it out pretty quick, and I'm not a copy and paster. Every visit is its own narrative and story.
Now, if you're seeing 18 to 20 patients in a regular full day and you're not doing any charting during those visits, how do you get those notes done, even dictating? I'm just trying to imagine how this would work and still get to dinner by 5:30. Tell me a little bit about how you actually pull that off. And of course, that includes billing as well.
Right. So, I have some templates, if it's a normal well baby, I have a 0 to 6 months and then like a 9-month to 24-month to toddler age and so on, because except if there's some abnormality, you can just write that separately. So there is some template involved for the well visits, but otherwise then I'll just dictate the physical and the machine reads it really well. So say it takes 5 minutes to dictate each one. I have a 90-minute break at lunch from 12 to 1:30. Even if I see 12 people over that time, I could usually, if I haven't done any in the morning, knock it out within an hour and still have time for some phone calls there.
Now, I'd like to get your thoughts a little bit on your decision to be a solo practitioner. Now, just to review, after your residency, you and your wife went off to Thiel, Utah. How do you pronounce that? Tooele, Utah, which is not exactly a metropolis. And if I recall, it was a pretty remote location. Your wife was on a J1, so you were sent out there and you built a practice, I think, literally from scratch. Can you just tell me a little bit about what happened? I mean, am I right about that? What was it that you had to create when you got there?
Well, we were 2 years out of residency. She was doing her fellowship in pediatric endocrinology at Brown, so I was in Massachusetts. And then somehow the rules changed for a married J1 physician. married to an American citizen, and she had to find kind of a waiver job. So she sent letters out to different counties, starting in Massachusetts and going west, and we finally got a positive hit when we reached Utah. So it was called a frontier area. I think it's less than 3 people per square mile, or whatever the definition was at the time. So she was sponsored by, at the time it was Community Health Systems, to work in that area. It's a rural area. And so because I was a physician, they had this deal where it was called an income guarantee. So I'd build my own practice and I'd own it. And they would guarantee my income up to a certain amount for the first year, as long as I stayed in the community for 3 years. So it was kind of like a loan to keep the practice going and keep my income while I was building the practice. So yeah, I mean, there was no internet back then. It was just a totally different world. And so there was a lot of trial and error, a couple letters from the IRS until I kind of got the hang of it. I read a couple books on business and how it works, and just kind of worked on it from there. So by the end of it, after getting some consultants to help me with the IRS, things were going pretty smooth, and I was confident enough to try it again when we moved back to Illinois to start the family.
So now what, just the physical structure of the practice that you created, did you actually have to put up an office?
So when we first got there, they were building a hospital. So the original hospital and the office building I was in was like 1950s era, like cinder blocks. They didn't even have a double door, so there was like these big desert flies zooming around all over. And half the time with the patients in there, I was with a rolled up chart whacking these flies. And so some of the phone system to get it proper, we'd wire that, and then at the time it was like dial up. So if I wanted to have some access, in 2001, I started with a 7200 bit dial up or whatever it was, and there were some very rural areas in there. There was patients without phones in some of the canyons of the valley there, and so there was a few technical challenges, but you're still able to see patients. They call the main line, they come in, you see them, you whack the fly, and they're on their way.
Now, if I recall, you were on call every night, all the time, for something like 4 years?
We were there 3 years, and so all the weekdays were calls. The first year, I was med peds and she was pediatrics, so we were the only 2 pediatricians in town. So after the first year, some of the family practice docs in the area got them up to speed on the neonatal resuscitation and so on. So we'd swap weekend calls so we wouldn't have to go in so often for the neonatal stuff. So it was just a regular nursery there, so we had to do everything. We had to do the intubation, the bagging, et cetera, et cetera. They didn't even have a baby ventilator. And then if there was a sick baby, you'd have to wait for the transfer from Salt Lake. And so there were some nights where if you get called in and it was a sick or premature baby, you're there the whole night. So weekdays, we did our own call. We did all our own call for the first year. And then after that, it was like 2 weekends out of 4. It would be like her weekend, then my weekend, and 2 other family practice docs. So the second 2 years after we did some education, we were able to kind of expand the call system.
And what do you remember about the patients who came to that practice? What kind of crowd was it?
Well, there's a majority crowd in Utah, and so that was probably about 70%. And they're big families, as it is in many rural areas, and especially in the LDS religion. And but they loved having us as doctors. I mean, it was just so rewarding. Even if you didn't know anything up front about a certain situation, you could read about it and call them back, and they just so much enjoyed having us in the community. So it was really a positive, just fun experience to be out there and helping because we brought all our modern knowledge and education to the town, and just extremely friendly. They were always inviting us for things, and honestly, we ended up with, I think we each had like 3 Book of Mormons because people were sharing their religion with us, and fun time. So yeah, Utah was still and is my favorite place that I worked and lived. I have a lot of fondness for that. Just in general, though, in primary care, probably in any specialty, the 3 years I was in that rural area, that was more education for me than all my previous medical training.
Can you tell me a little bit more about that? What kind of things did you learn?
Well, I would be called, say, to the emergency room to assist with the pediatric trauma, and I work with the trauma surgeon, and if there was an ER doc that day. There was a heart attack one night. The community health systems ended up building a new hospital. I can't remember, it's 15 beds or whatever. But for a while there was no ICU doctor. The one guy comes in with a heart attack. We can't transfer him because of the snow or he's too unstable or whatever the reason. So it was great. The University of Utah cardiologist, he allowed me to keep calling him. And I managed this guy's MI. I think we gave him TPA or whatever was being given at the time. And he just walked me through the whole thing. So I was kind of his surrogate from the cardiology at the university, being in the ICU all night taking care of this guy. Same with neonatal resuscitation. You go in there, the poor babies, at 28 weeks or whatever. You're the only one for 60 miles that can intubate the kids, so it's a little bit of stress. So you get the tube in, you get the umbilical line and so on, and then you wait for the transport. If it was good weather, they'll bring the helicopter. If it's not good weather, then of course it's the ambulance, and it takes a lot longer. And some nights the weather, how it snows out here in the West, sometimes they just can't come. So you just got to stay with either the baby or the sick person until you go. So it was like there wasn't very many specialists to back you up. There was a surgeon, and he used to go from town to town, but he wasn't always there at that location or in that neighborhood. So there was only one OB in town when we got there. And, I kind of felt bad for that guy because, that's a lot of work to be the only guy. And luckily, by the time we left, he had a partner and there were some other people covering as the university started to push out into the Tooele area.
And then after you left, you came to Coal City, Illinois, if I recall. Is that correct?
Right. So Moore's Hospital, which is the county seat of Grundy County there, they offer a similar program for physicians to come where they guarantee your income for the first year, and then you stay in the community for 2 more years. And I ended up staying there for 7 years. It was about an hour and 20 minutes outside of downtown Chicago, and a lot of my family lived around there. And so I built the practice. I was off the income guarantee in like 5 months. It was a lot of fun. Met a lot of good people there. And, it was a little challenging because both these places, being in kind of rural areas, you round in the morning, see your patients, go to the office for the day, round in the evening if needed, and then usually round on the weekends. And then we'd all share what they call board call. So you'd get assigned 2 or 3 days a month where you took all the unassigned ER admissions to the hospital. So that could be either an easy day or a challenging day. And I still remember at Morris there, it was a Sunday. I had like 14 admissions. So I worked all day. So I went back at 10 o'clock, slept until 3 a.m., finished up my admissions, and then spent my Monday in the office. So I still remember that because it was kind of a painful event. But it's interesting, because you get to meet 14 new people. So.
And if I recall, many of your patients were uninsured or on Medicaid. Can you tell me a little bit about what you did when patients were not able to pay for their care?
Right. So across the board, under my own control, when I'm self-employed, and I even do it now, is I give a discounted rate. And a lot of that depends on, if they're not working, it's going to be a lot lower rate because I know they're coming really out of necessity. And people would appreciate that. They'll, send you some Harry David pears or something, or they'll bring in some vegetables from their garden or whatnot. But, honestly, if someone needs to be seen, then, can you really say no or say, oh, sorry, it's $200 up front? Well, no. I mean, they need to be seen. If they walk in your office, it's kind of your responsibility, I think at least, to take care of them, whether or not they can pay at that time. I was really lenient about that, maybe for better or for worse, but, I always had that kind of low, decent salary that I was happy with, and it didn't really bother me much, and I was still able to help some people.
Tell me a little bit about what people were typically charged if they were uninsured. And I know it was a sliding scale, but if you could just say a little bit more about that.
It was kind of nice in Illinois because I had this deal with the hospital where I'd draw blood in my office and I'd basically buy the labs from the hospital. And like a CBC cost me $3, and BMP, a basic metabolic panel, was $4 or whatever. The most expensive one was TSH, and that was like $50. So I was able to, if they needed labs, not only give them, $50 for the visit, but then, maybe $10 or $15 for the blood work. And it was just an even thing for me where, I'm just paying for what it costs. And so they're getting a great deal. So there's ways to get around the complexity of the health system when people are having difficulty with finances.
And how do those numbers compare to what you would get paid with an insured patient or a Medicare patient?
Yeah, that's really interesting. So that was 10 years ago when I left Coal City. So a 213 from Blue Cross or United, perhaps $75. Okay. And Medicare was right around $50 for that. And Illinois Medicaid, unfortunately, was very low. I think it was about $30. So it was somewhere between the Medicaid and Medicare. It was basically about the Medicare reimbursement that we were giving. And, what Medicaid pay well for in Illinois was the well baby checks. So a well check to encourage good health and prevention was somewhere in the $80 range. So that was a much higher pay than a sick visit. So you can see what we do. If people are willing to take all the insurances, we will subsidize the low payment of Medicaid and Medicare by seeing, an equivalent or more version of commercial patients. So in my current practice, I'll have maybe 60% commercial and 30% Medicare, and then 10% self-pay or Medicaid. So I can still keep seeing, I'm open for Medicaid children. We never close to that. So if they're in our service area, I don't deny them if they're on Medicaid. And so we can continue to do that as long as I have enough commercial patients to subsidize the low payment from the state. And that makes it, I think, more fair for everyone across the board.
Now, after you left Coal City, you came out to Colorado, and if I recall, you worked initially for a large corporate entity before you decided to break out again to form your own practice. So can you just talk a little bit about what it was like working for a large corporate entity and what prompted you to then decide to go back to being a solo doc?
Right. So we left Coal City for two reasons. My wife didn't like the Chicago winters anymore, so I told her to pick a spot in the country, and so we decided to come back to the mountains. And it's an even mix between being nice and warm for her and having the wintertime for me. But the second reason we left is there was a new healthcare law, the Affordable Care Act. And so I read that act several times. And it's not as long as you think because everything's in duplicate for the Indian Health Services. And so what I realized upon reading it is that the little guy was going to get squeezed. Okay. And by that I mean is the government wanted to basically negotiate rates with big corporations in order to lower the price of healthcare and so on. So I thought that was a good time to get under the wing of a big corporation. So after 10 years of being solo, I actually joined the largest healthcare company in the country. And so there was a Denver division of that. So I was an employed physician for 6.5 years. So there's a lot more compliance and this training and that training and all the things that are important to a big company in business, but not adding any value to my job. So I promised myself the first year I'd just observe and not make any comments just to see how things work. So I did that. And after that, it was hard to keep my mouth shut because things were so inefficient and just nonsensical. Nonsensical, I mean, why do we do that? Waste 5 minutes of the assistant's time and there's no reason for it. And then you get the answer, well, we've always done it that way. All right. Well, maybe we should look at that again. So anyway, we went through a lot of staff changes. So from month to month, I'd have a new medical assistant working with me. And to get a good flow going, it's very frustrating to have a change in staff where they don't know how it works. Change in management, both your immediate supervisor, the clinic director, and also supervisors above that. So it's a really difficult environment if you have an independent kind of mind thinking to fit into this basically a cog in the machine type job. So I got frustrated over time and finally planned my move on my own.
What are some examples of nonsensical things that you saw in this large corporate environment that was just kind of time wasting?
So I wanted to keep my schedule the way I designed it over the last 10 or 12 years, and it's the way I'm using it now. So I still have those 4 empty slots in the morning, 15-minute slots for same day, and 4 empty slots in the afternoon. So the business guys, they watch my schedule every day, and they're always on me and saying, look, you've got all these open slots. You got to see more new patients. New patients was a big thing because you get an extra 20% pay for the initial visit. So there's a big push in corporate medicine for new patients. So anyway, I'm like, well, look, I said, look at by the end of the day, just because it's open now doesn't mean it's open at the end of the day. So as it turns out, for the majority of the years, I was the highest producer in terms of visits and RVUs of anyone in the system. Yet they still had to keep getting on me for the same day visits that were open at the beginning of the day. Right. I'm like, guys, how can you justify giving me a hard time about this when I'm like the highest producer in terms of volume? So that's just one example. And, it's just so frustrating. I try not to think about it.
Yeah. And so then you decided to break out on your own again. And tell me a little bit about the current practice you have and how you came to choose where you would be and how it would be configured.
Right. So I chose a place that was close to my house. So I'm only about 3 miles from where I live. That way, if the car breaks down, I can walk here or take my bike. So some days I bike to work because there's a shower in the building. And I wanted to have my own staff, and I pay them really well, and they do everything for me, and they're very loyal. So, it's really important to have a good staff because then you can concentrate, just like you say, all the paperwork and the dictating. You can concentrate on the part that you absolutely have to do yourself, and then all the other stuff the staff can work on. So that saves time. And instead of them, rotating in and out like every couple months with new people you have to train, they're well paid and they have a really good benefit package. So they could easily stay here 5 or 10 years and enjoy it. The other important thing that's separate from a company is that I let them, I call it own their jobs. So they know essentially what they have to do and I give them some guidelines and then they get to figure out how to do it. Okay. That way they develop their own processes, their own checklist for the day and how they're going to organize it. So I don't say, do all this part first and then do this part and do this exactly this way. No. I said, this is all that needs to be done for the day and just find out what works best for you because every person's a little different. That way they actually feel like they're part of it. They're really contributing because they have their own way of doing it. What I saw a lot of at my corporate job is that the office manager be over their shoulder the whole time. You have to do it this way. You have to do it. And, that just drives people crazy.
Yeah, they're very different styles of leadership. Tell me a little bit about how you hire and train your staff. How do you decide who to hire and how do you train them?
Yeah, so most of it's been kind of people I've already known or word of mouth, except for the one lady I hired. She was someone that I knew, and she's an expat from Switzerland. Her husband works here, and she had worked in a pediatric office in Switzerland for 12 years, but being in the U.S., she hadn't worked at all for 7 or 8 years. So I took a big chance on hiring her because it's a different medical system. And as it turned out, she loves working here, and she's one of my best employees. So there was a little risk there. In terms of the other ladies, one of them I knew from prior working at Health One, and she too got frustrated and went back to a different job. So I enjoyed working with her, and I hired her from a concierge practice. It was a little expensive, but totally worth the money for her expertise. And the gal who's a front desk, she actually migrated to me when one of the pediatricians closed her office. So I've known her parents for a while, and I know her family, and they're a solid family. And she had been working at like a wings place, and I'd gone over there, and because my kids were at the church school, so I was going over the wings place. I'm like, what are you doing here? She's like, oh, I finished my degree, and this is all I could find. I'm like, all right. I said, why don't you call me? So she ends up being like a phenomenal front desk person. Takes care of all the phones, all the correspondence and stuff. It's great. So some of it's just people and some of it's kind of as you go through the system, you hear about people, and some of it's training, like the lady from Switzerland.
And you understand, you mentioned that they also get full benefits.
Yeah, it's a great gig. So the part-timers aren't part of the health insurance, but full-timer, the lady at the front is a full-time and she gets health insurance. And of course, it's for my family. It's really expensive if you're a small business and you have to buy a high deductible plan. I mean, it's really expensive. But then the best thing is this 401k, and I learned about it when I was in Utah, and I had it in Illinois, and I have it now. So this is a great gig that they essentially don't have to put anything in if they don't want to. And then the company gives them 3% of their salary in the 401k at the end of the year. So 3% is mandated by the plan. And then there's an optional percentage up to 25% of their salary. So for instance, I would give 3%. that means I have to give myself 3% and all my employees the exact same 3%. That's mandated in the plan without them putting anything in there. But then if there's extra money at the end of the year, I can match, like I think last year it was the 3% plus another 9%. So 12% of their salary, the company puts into their 401k, and they don't even have to put a dime in there, and they still get that money. So then that company money vests over 6 years, which gives them a really good incentive to stay, because that's like free tax-free money. And one of the employees, she's only in her 20s. I mean, she can work here 5 years with that kind of match. She probably wouldn't have to save any more retirement funds, and by the time in 40 years she turns 65, she can retire on that. So it's just a really sweet gig for them.
So, what's extraordinary to me is that you have spent almost all of your career, except for that short stint in the corporate world when you came initially to Colorado. You've spent your career as a solo doctor, and what you describe is a practice environment that you built and created yourself, where you hire the staff, where the staff is well paid, has excellent benefits, has a high degree of loyalty, where you get to see patients in a way that you're comfortable doing, where you're able to give them your full attention with just a blank clipboard, where you're able to get your notes done and get home to dinner with your family, and where you have autonomy as an independent practitioner, and where you're even able to weather a pandemic and to do all that with joy, to find pleasure and meaning in your work. And many people think that that's a way of practicing medicine that disappeared, 50 or 60 or 80 years ago. So are you a dinosaur? Are others people doing this? And how do you account for the fact that you're able to have this type of a Norman Rockwell practice in the new millennium?
Right. I think this last time, because it's a decent sized metropolitan area, was a little bit of a risk because the area is owned by all the big hospital corporations. But, I was getting towards 50 and I thought to myself, I don't want to be that guy at 70 years of age that looks back and says, I wish I did this or I wish I did that. And so I thought for the last 25 or 30 years of my career, I kind of wanted to do it my way as best I could with all the knowledge I had made. And that's been kind of a guiding goal, where I can give the best possible care and provide an outstanding opportunity for my employees and enjoy it as I go. And I think if you have the right kind of goals in mind and kind of learn as you go through the process, it's really a lot of fun. I mean, it's really interesting. Plus, you're doing the medicine, which is what you were trained to do. So I don't think it's a dinosaur model. I just don't think that people have seen enough, examples of the type of things that can be done if they decide. I have a slideshow that I give to all the residents, basically asking them, why as an independent thinker, you just sign a contract at the end of residency, right? And just to get them thinking about it, I think there's been so much talk that, you have to do it this way, or you have to do it, or you can't make it on your own. Well, if you hear that all the time, then you're never going to take the risk to try it. But I just absolutely I'm so glad that I went this way again. And I've actually already now helped there was another 2 family practice docs, and they had contacted me, and I kind of gave them all the details on a startup, and they'd actually recommended, they're like, look, you should charge for this. You should be a consultant for this because you know exactly what to do. And so I, put a little blurb on my LinkedIn account about that. But right now with the pandemic, I think there's going to be even more consolidation.
And healthcare costs go up, I think, when care gets into the corporate structure. Is that correct?
Right. So the university has a for-profit division in this area, and I think a regular physical is in the $900 range for the adult physical, and that includes a facility fee, whereas I post all my prices online. I think the highest charge I have is $250. In fact, I think I've kind of priced it out. Guys can fly from New York City, see me for a physical, and fly home, and it would probably be cheaper than going to SUNY or wherever they have out there. So yeah, it can be cost effective, and it's very good medicine for me. I'm solo, but I think the ideal practice would be 2 or at the most 3, because then you can cross cover and have more opportunity for time without the pager. But the caveat would be is you have to know the other person's patients, so that when you're on call, it's just as personal an experience for them as it is for your own patients. And that's not too difficult. Over time, you get to know everyone.
What is your coverage arrangement?
The first year I used some locums when I went out of town, but that was kind of a huge hassle. Not necessarily the cost, but with the EMR and the calls, and so now I have newborn privileges at the hospital, so I'll have the pediatric group cover me at the hospital, and I just take my own call and keep in contact with the office. And I provide a decent enough service that most people are happy that I'm out of town when they call. They're like, oh, good, he needs it.
They're glad you're getting a break.
Right. Yeah, exactly. And so I get my pages through an extra cell phone that I have, and then I call people back. But in reality, especially since the pandemic, if I get one page a week, that's a lot.
What about before the pandemic? It sounds like you were on call 24/7?
Yeah, still, absolutely. And even then, really only like 2 or 3 calls a week at the most. So people, it's much different than it was like 20 years ago. In the 90s when I first started, people would call all the time. And I think for whatever reason, they're much more respectful of my time. So it's rare for me to get calls, on the weekends or at nighttime. And, I can't even remember the last time I was called between like 10 p.m. and 6 a.m. So people are very, very respectful of that.
Now, I wonder if that may also be because you're so easy to see the next day. You keep all these slots open that you fill up in the morning or in the afternoon. So they know that if it is, unless they need to talk to you right now, you'll be there for them and they can see you in person the next morning.
Right. I think there's some of that. And also, we have a really nice flow process in the office where like medicine refills and little things get taken care of on a timely basis. So, it's rare for someone to call me and say, hey, I need my prescription refilled. You forgot, or this was overlooked or whatever. So that almost never happens anymore, the medicine refills.
Do you have any data on hospitalization rates or outcomes for your patients compared to others in the area?
I'm in one of these, I think it's like an IPA where you not contract, but you're with a bunch of docs so that you can negotiate a higher rate.
Do you mean an ACO?
Yes. It was remarkable because they test us on a lot of things like how many Medicare physicals you do or ER visits per 1,000 and so on. So our group with a mixed population of adults and kids, or my group, we had the second lowest ER visit rate. And a lot of that, I think you're right, is from the same day visits and just the education from the staff. Like, look, if it's not an emergency, we can see you here or the next day.
Mm-hmm.
So we do pretty well in the quality department, and it's a lot of fun to do everything, basically here without having to use the ER unless it's obviously an emergency.
The last thing I wanted to just talk to you about is your care for kids who have disabilities. I remember years ago when you discovered that you had Klinefelter syndrome. This was when you were having difficulty conceiving. And at the time, I was struck by how unabashed you were, how you just didn't feel any need to try to be secretive about it. In fact, your sort of your natural curiosity came out. You were sort of like, I remember getting an email from you. It's like, hey, I got Klinefelters, isn't that cool? And that was just so refreshing. Also, in many ways, you are just an example of how you can't generalize about any condition. I mean, the characteristics of people with Klinefelters, some of the physical characteristics, I guess in hindsight are there. You're kind of skinny and thin and tall and so forth, but you don't have the behavioral or cognitive stereotypes associated with that condition at all. You're one of the brightest people I know. And so I'm curious about how you communicate about that with patients when you can, show your support for families that have kids who have various types of congenital disabilities, because I know that's been a particular niche and interest where you've been able to help people.
Right. And so I don't necessarily share that with many of my patients. Occasionally if, there's an infertility issue that someone's discussing, I might mention it. But I do like taking care of a lot of kids and even young adults after they graduate from their pediatricians. And so a lot of it is maybe the way I approach it and dealing with talking to the family. So even with a disability, I tell families, I'm like, this isn't, a lifetime sentence. This is a fluid and malleable situation. I said, there's a lot of outcomes. You can be reading to them a lot. You can work with the therapist. You can do this. You can do that. So it's not always just the diagnosis. So much of it, I tell them, is, the interactions at home and the opportunities and so on. And it's really a nice way to look at it. So, even kids where there might be an issue, I'm like, look, everyone I assume is 100% when we start. And if we give that expectation in the beginning, then things might turn out better than necessarily what the book says later on, just because we have that high expectation from the start. And I think people really appreciate that because, it's not just a certain diagnosis or a certain problem. It's a phase in time where, we kind of understand a little about this now, but there's still a lot of potential left.
What if, for instance, you're caring for a child who has, or a young adult who has Down syndrome, where the family has concerns about the progression of that condition, the fact that kids, as they become adults and then midlife adults, may lose cognitive function, and then there are questions about what will happen when the parents are no longer able to fully care for them. So have those conversations come up for you when you're caring for families who have a child with a condition like that?
Oh, absolutely. Absolutely. So with all the kids, I have a number of CP young adults that are like wheelchair bound. They can't speak. They're incontinent. And unfortunately, I think for society, there's less Downs people because they're like the best humans on the planet. But even then, we talk about that at multiple visits. Like, okay, do you have it set up? If you're not around, who's going to take care? And so we go by it stepwise as I get to know the family. And most people already have things set up. These are some of the finest parents that you'll see ever. They usually know more about the conditions and their children than I do. So half of it is them educating me. And then, I always make the offer like, okay, I said, you're doing almost all of it. And you're an amazing person. What can I do to help you? Can I sign stuff to fill out this or help you with this or help you with respite? So it becomes a collaborative care where I'm not necessary. They're really more knowledgeable than I am, the parents or the caregivers of the Downs kids or the CP kids or the kids with disorders. So it's a team effort when they come in where I'm offering to help them more so in terms of getting, assistive devices or computers where they can interact, or, for Downs kids to make sure that they're getting their, heart checked or this and that. So I offer more than necessarily recommending because the families usually know more than I do about the situation.
I think that's a critical point. And part of, I guess, the fun of being a physician is that you learn from your patients.
Yeah. I mean, really, the families of the developmentally delayed kids and the young adults, those parents are like the angels on earth. I mean, it's amazing what they do.
Do you think that's because it brings out the best in people to be a parent of a vulnerable child? Because obviously those children get to choose their parents.
Yeah, to bring out the best is one way to look at it. But I think it focuses the true human caring behavior of the parents. That's probably present in everyone, but it intensely focuses it because they need to, because they're caring for someone that's completely dependent. Most people can channel that kind of true human caring for the first year of life when it's an infant, but, it's kind of exhausting. But these people that like true caring human element that's probably present in everyone, they extended for 10 years, for 20 years, for 30 years, this total dedication. I mean, it's just a phenomenal thing to see. And I'm just so amazed when these families come in. It's just a remarkable thing.
You're now in your mid-50s and we're in the middle of a pandemic. You have a practice that you love. What do you see ahead?
Well, I'm just going to keep doing what I normally do. I'm actually kind of hoping I get to help out a little bit in the hospital on the weekends if it becomes more severe so I can learn a little more. Hopefully it won't come more severe, but we all know it's going to be wintertime soon. But I don't know. I'm just hoping I can stay healthy so I can do this for another 25 years because I really enjoy it. The other thing is I mentioned about the residents and just about all of them go into hospital medicine. So I really try and, show them the fun and more exciting and curious parts of medicine so they can possibly consider doing outpatient medicine. It's kind of a tough conversion for them because, you can work 10 shifts in the hospital, 12 hours each, but I don't know if those guys get burnt out, but it doesn't seem very rewarding to just see someone for a couple hours and then, be on to the next person and not see the person the next day and never know what happened. I call it fractured care, this kind of hospitalist medicine, because it's just all piecemeal where you don't really know the full person. So I was hoping, to get more of an outpatient presence in the internal medicine and family practice. Family practice is pretty good about it, but not internal medicine. And then that's about it. I really don't, I think I've made most of my goals. I just really enjoy it. And so I'm going to keep doing what I do.
Well, I think the message, as I see it, for young physicians, when I share this with them, is that here you have 3 times in your career, first in Utah and then in Illinois and then now in Colorado, done it solo, started a practice from scratch, built it up, and hired your own staff and given them good pay and good benefits, developed tremendous loyalty and found great joy. And certainly your patients love you. I know that because it's online, and I saw it when you were working as a resident more than 20 years ago. And people don't think that's possible anymore, and yet it is. It's absolutely possible, and you've shown it repeatedly. And you're looking forward to just doing more of the same. And I think that's just an incredible message to share with people out there who think that opportunity and that way of living is gone. It isn't. Clearly, it hasn't been for you.
True.
So that concludes episode 1 of my conversation with John Scala. Please turn to episode 2 to learn about his experience with the COVID pandemic.